Every breath is part of a continuous mechanical chain. While moving air in and out is the most visible sign of life, the ultimate goal of the respiratory system is gas exchange. Understanding how that exchange succeeds or fails is high yield for medical board exams. The cycle starts with inspiration, an active physical process. The diaphragm contracts and moves downward, forcing the thoracic cavity to expand. This increase in volume drops the internal pressure, drawing outside air into the lungs. Normal expiration requires no muscular effort. It relies on the natural elastic recoil of the lungs and chest wall snapping back to their resting state, which pushes the air back out. Once air enters the chest cavity, the focus shifts to the physiological barrier, forcing those gases to successfully interact with the blood supply. Not all inhaled air makes it into the bloodstream. Dead space is the fraction of a tidal breath that completely fails to participate in gas exchange. We categorize this wasted air in two ways. Air trapped in conducting tubes, like the trachea and bronchi, is anatomical dead space. Air that reaches the alveolus but lacks a corresponding blood supply is alveolar dead space. Effective alveolar ventilation is the volume of air actually performing work. You calculate this by taking the total tidal volume and subtracting the dead space. This represents the volume that reaches the blood. This calculation dictates a strict mathematical law in the body. Alveolar ventilation has a direct, inverse relationship with arterial carbon dioxide levels. When alveolar ventilation drops, the PaCO2 on the opposite side of the scale is forced to rise. Therefore, any pathological increase in dead space directly robs the patient of effective ventilation and leads to the retention of carbon dioxide. Once air reaches a functional alveolus, it must cross the microscopic alveolar capillary membrane.
The transfer of these gases is governed by Fick's law of diffusion. The different gases face different speeds. Carbon dioxide diffuses approximately 20 times faster than oxygen across this specific barrier. If a disease causes this membrane to increase in thickness, oxygen particles begin to fail the crossing and bounce back. Meanwhile, the faster CO2 particles still manage to traverse the thicker wall. Because of this gap in diffusion speeds, an expanding membrane causes a patient to suffer from hypoxia long before they show signs of retaining carbon dioxide. Gas exchange requires the amount of air hitting the alveoli to match the blood flow past it. In a healthy lung, this ventilation-perfusion ratio, or VQ ratio, sits at approximately 0.8. This split screen shows the two extremes of VQ mismatch. On the left side, the alveolus is inflated, but the capillary is blocked. On the right side, the blood flow is normal, but the alveolus is collapsed. Using what we've discussed, identify which side represents a shunt and which represents dead space. You have 3 seconds. Ventilation without perfusion is dead space, creating a high VQ ratio. Perfusion without ventilation is a shunt, pulling the VQ ratio towards 0. Failing to match air and blood flow disrupts the entire chain. Regardless of which pathway is obstructed, VQ mismatch drives systemic hypoxia. Gravity dictates that pulmonary blood flow is not evenly distributed. Because blood is heavy, it creates distinct pressure zones from the apex to the base of the lung. At the lung apex, known as Zone 1, high alveolar pressure exceeds the arterial blood pressure. The inflated alveolus compresses the capillary shut, halting flow and acting purely as dead space. In the middle tier, Zone 2, pressures allow for intermittent pulsatile flow. At the base, or Zone 3, arterial pressure dominates. The capillary remains wide open, allowing the continuous flow necessary for maximum gas exchange. Since gravity pulls blood downward, the base of the lung performs the vast majority of the physiological work for the body. A massive pulmonary embolism provides a clear test of these interconnected systems, triggering a predictable cascade of failures. A clot in a lung base capillary shuts down Zone 3 perfusion, converting functional tissue into massive alveolar dead space. Effective alveolar ventilation drops, causing a sharp increase in PaCO2. The non-perfused Zone 1 expands downward, overtaking lower lung fields and crushing remaining functional capillaries. Dead space is wasted air. Alveolar ventilation controls carbon dioxide elimination.
and VQ mismatch drives hypoxia. These three mechanics form the core logic of respiratory physiology.